module today. So we've talked about, tachycardias and bradycardia so far. Today, we're going to talk about acute coronary syndrome. And then, next week when we're there, we'll talk a little bit more about heart failure and echo ultrasound as well. And again, feel free to jump in with questions or just to share your experiences or, what you've seen before. There's definitely a lot for us to learn from each other, or feel free to kind of ask questions in the chat as well. That's also open for us. So let's talk about acute coronary syndrome. So some of the risk factors there are, there's a number of them, including hypertension, so like high blood pressure, diabetes, high cholesterol, tobacco use, and kind of family history of heart disease. So all of these are risk factors that we see that increase patients' risk of either having an acute coronary event or having a heart attack, which we'll get into a little bit more into. So acute coronary syndrome really is kind of a spectrum, right? So it starts from something simple like stable angina, and it goes all the way until, a myocardial infarction or a heart attack, which is kind of the common things that we know about. So for stable angina, this is basically when you have chest pain, which is due to cardiac ischemia. So there's a decrease or loss of blood flow to the heart. And in order to categorize it as stable angina, it usually occurs with exertion. So patients have to be, walking or running or climbing the stairs when they have chest pain to really classify it as stable angina. For patients with stable angina who come in with chest pain, like they were, walking up a hill or something, and they started having some chest pain. If you get the EKG and you check the troponins and they're negative, most of these patients can be discharged home with close cardiology follow-up, at least in the US here. Have you all seen like stable angina before, and how do you usually approach taking care of these patients? You can share, or you can put it in the chat as well. And these are pretty simple, so we can also move on to the next category. So unstable angina is a little more, it's kind of the next level up, right? So we started from stable, then we'll move towards unstable angina. So unstable angina is the same kind of physiology, right? So it's also chest pain due to cardiac ischemia. So there's a decrease in blood flow to the heart. Other kind of like chest pain equivalents, such as shortness of breath or chest tightness, all of those are kind of considered, can fall in the category of unstable angina. So if a patient comes in with shortness of breath or chest tightness going on, that's pretty much equivalent to chest pain when we're looking at unstable angina. Unstable angina is what occurs at rest. So patients, maybe they woke up, or they were sitting on a couch, or they were kind of like, just resting there when they start having the pain. When they have that, that's how we classify them as unstable angina. Sometimes you'll see some EKG changes, such as ST depressions or new T-wave inversions, which we'll kind of look into a little bit more later. But those are all changes that we can see when patients have unstable angina. One important thing that helps us distinguish this from everything else is that there are no troponins. So, patients with unstable angina, their EKG can have some change. They can have some chest pain, but they should not be making troponins. So if usually we do at least 2 troponins here in the US, and they should both be negative, or they should at least be unchanged. So they shouldn't be, the patient shouldn't be increasing or even decreasing. The treatment for unstable angina, aspirin is kind of the one medication that's been shown to help with mortality of patients. So we recommend 325 milligrams of chewed aspirin. And for these patients, it kind of depends on the story when you're talking to them. You can get a cardiology consultation and have them kind of help with deciding if this patient needs to stay or if they can go home. And if you admit these patients, you're usually keeping there for telemetry monitoring, so kind of putting them on a heart monitor and looking and kind of watching them at least overnight or over 24 hours to see if there's any new heart rhythm that's going on. You can admit them for serial troponin, so they'll continue checking troponins like every 2 to 4 hours and seeing if that increases or not. And you can also admit them for stress testing. So depending on your hospital, sometimes some cardiologists will keep them on, overnight to stress test them in the morning and have them walk on a treadmill and see if there's any kind of changes going on with their EKG. Any questions so far? Anyone want to share anything? If not, we'll move on to the next one. So we're going to talk about a couple different scores. The first one is the TIMI score, which is not used as much anymore, at least in at UC Davis. This is really for patients with known unstable angina or NSTEMI. So it's not a really good score for diagnosing patients. It's for kind of risk stratifying patients, or if patients that have unstable angina or have an NSTEMI before, you can use a TIMI score to see how much risk they have to have a cardiac event coming up. So again, these are some of the things that we look at for the TIMI scores, right? We have their age, if it's over 65 years, some of the risk factors that we just talked about at the beginning of the lecture, including high blood pressure, high cholesterol, diabetes, family history, and tobacco use. Any known coronary artery disease, especially if they've had a cath before, and their stenosis is of angina in the past 24 hours, or any kind of ST changes with greater than 0.5 millimeters on the EKG, or positive cardiac markers, or any kind of positive troponin. So these are all the different scores that the TIMI score takes into account. And again, these are really only used for patients who are known to have unstable angina or known to have an NSTEMI. The next score here that we're going to talk about, the heart score. This one's a little bit easier to use, right? We use it more in the emergency room. So there's, this is pretty well validated externally. And so there are a number of things that we take into consideration when we're talking to the patient, right? The first one is pretty subjective. So it's whether or not, the history is, slightly suspicious, moderately suspicious, or highly suspicious for cardiac ischemia. And that's really it's a very subjective and clinician-based thing. So it's really based on you kind of talking to the patient and seeing, what you think, how serious it is. There's the EKG. If it's normal, it gets 0 points. If there's any kind of what they call non-specific repolarization disturbance, so any kind of minor change, they would get 1 point. And if there's any kind of ST, usually ST depression, because if it's elevation, we would consider it something else, then they would get 2. And initial troponin level is what we would check to kind of decide where the patient is in terms of the initial. Has anyone used a heart? If anyone's used a heart score before, to share about it, feel free to share.
The only thing I was going to mention was
really good addition. Any other thoughts? Otherwise, we can keep going.
In UMC, we don't usually do heart score. We just only use the TIMI score to evaluate the patient with heart with chest pain.
You use the TIMI score more?
Yeah, TIMI score. Just only use TIMI score. Sometimes and very little time we use a heart score.
Sometimes use. So when you use the TIMI score, do you use it for to admit or discharge patients, or using it for cardiology referral? Or how do you use the TIMI score usually?
Yes, usually for the check patient in emergency department.
Okay.
Yes.
You can determine from there.
Yes.
Yeah, we don't use that one, so that's good to know. I'd be interested to kind of see more about how you'll approach that one. So NSTEMI, or non-ST elevation myocardial infarction, this is when you have EKG changes, right? Such as ST depressions or T wave inversions, where the T wave, which is normally upright, is flipped upside down. Again, this is when you start seeing positive troponin. So the troponin is really what we use to separate the unstable angina from the non-ST elevation myocardial infarction. There's no troponins in the unstable angina, and you do start seeing troponins in an NSTEMI. For these patients, again, you want to give aspirin, 325 chewed, and you can give Plavix or clopidogrel as well, unless the patient has a bleeding risk. Usually the GP2B and 3A inhibitors, such as abixizumab and tirofiban, we usually hold those until they're about to go to a PCI. So we save that for the cardiology to give. And there's two kinds of blood thinners you can do. You can either give enoxaparin or Lovenox. And you will give that 1 milligram per kilo sub-Q twice a day. And this is recommended by the American Heart Association for moderate to high-risk patients who have unstable angina or NSTEMI, unless they're planning on having a CABG in the next 24 hours. But for these patients, you do need a kind of, it's generally safer than the unfractionated heparin. However, if they, do have any kind of kidney problems, you do have to, adjust the dosing for that. And the nice thing about using Lovenox is you don't have to monitor labs. And then the next section is, and then if you don't want to use Lovenox for, because they're having surgery coming up, or they have a lot of kidney problems, you can do unfractionated heparin. And usually for that, you do a bolus of around 60 to 70 units per kilo with a max bolus of 5,000 units, followed by a drip around 12 to 15 units per kilo per hour, with a maximum of 1,000 units per hour. Your goal APTT is 45 to 75 seconds, and you would consider using heparin if a patient is may have renal failure or they're about to undergo a PCI in less than 24 hours. In Vietnam, do you have a preference which one you use? Do you use Lovenox or heparin, or do you have another medication you like to use?
And usually we use Lovenox for the patients.
Use Lovenox more.
Lovenox, yeah. Lovenox.
Yeah,
And sometimes in UMC we use ticagrelor.
Oh, you use ticagrelor as well.
Yeah.
Yeah, usually Lovenox is a pretty common choice, but yeah, I've definitely had the ticagrelor as well. Any other questions so far on NSTEMIs before we kind of move on? I know the heart attacks is the interesting part, so that's coming up next. But any questions so far on NSTEMIs?
Yeah, in GMC, we receive a lot of patients with non-ST elevation myocardial infarction. And we evaluate the patient. Patient need to stay in emergency department to wait for GSA, or some patient stable, we transfer the patient to cardiology department. Yeah, we separate high risk patient, non-ST evaluate high risk patient and non-high risk patient. Yeah, high risk patient we wait for DSA immediately, only about 2 hours. In 2 hours, and not high risk patient we wait for upstairs to repair many things for them before transfer them to DSA.
Oh, awesome. Thank you. That's really interesting. Anyone else want to share anything before we move on?
I think that you missed statin, right? Because we have to give high dose statin, rosuvastatin, atorvastatin.
Oh yeah, for statin. Usually, so I think it kind of depends on the practice. Usually, my understanding is we tend to do that more for these STEMIs. Like we're going to go talk about it in a little bit about giving the atorvastatin. don't usually do it in the emergency room as much, but is that something you normally would do in the ER? You would give a statin for an STEMI as well?
Because it will have to decrease the inflammation with the high dose.
Oh, that's interesting. I have to look into that. That's interesting. I actually don't do that as much, but that's really interesting. I'll definitely look into it. Does everyone else give statin as well for STEMI? Maybe. We can come back to this one too. But yeah, I'll definitely look into that. I've never I haven't encountered that as much, but that sounds really interesting. I have to look into that a little bit more. So here is a sample EKG. So what do we see here? You can share the answer. You can write it in the chat. However you want to share is okay.
ST elevation with D2, D3.
Exactly, right?
Yes, inferior myocardial infarction.
Yeah, we see ST elevation. We see in 2, not so much, like maybe a little bit in 3. We definitely see an AVF here, and we see some depressions as well, right? And maybe up here a little bit in like V5. So this is a STEMI right here, right? So the STEMI criteria are like kind of what's colloquially known as the heart attack here. So the criteria that we use so far is if it's a male younger than 40, it's greater than 2.5 millimeters, so like 2.5, like tiny little boxes, in leads V2 or V3, or greater than 1 millimeter in all of the other leads. For males who are greater than the age of 40, it's 2 millimeters in V2 and V3 and greater than 1 millimeter in all other leads. And for women of all ages, it's 1.5 millimeters in V2 and V3 and greater than 1 millimeter in all the other leads. So here is when there's the EKG can actually show us a lot depending on where we see the ST elevations in terms of which vessels are being affected. So the lateral leads here are leads 1, AVL, and V5 and V6. And these leads correspond to the left circumflex or the diagonal branch of the left LAD artery. The inferior leads are 2, 3, and AVF, and this corresponds to the RCA or the left circumflex. And the anterior septal leads are V1 through V4, that corresponds to the LAD. So depending on where we see the ST elevations, it can kind of help us figure out which artery is occluded and which part of the heart is not getting enough blood flow. So reciprocal changes. So reciprocal changes are basically when we see ST elevations in part of the, in some of the leads, we can see ST depressions in other parts of the leads as well, right? So this is a mnemonic that I think is really helpful in terms of remembering where you get reciprocal changes. So basically this is a pail, right? And then so the P stands for posterior, the A stands for anterior, the I for inferior, the L for lateral, and the S for septal. So basically each of these corresponds to the next one in terms of where you'll see reciprocal changes as a general rule. There's some exceptions here, but for example, if you have a posterior ST elevation, you should see reciprocal changes in the anterior leads. If you have anterior ST elevation, you should see ST depression in the inferior leads. If you have inferior ST elevation, you should see reciprocal changes in the lateral leads. If you have lateral ST elevation, it can be both. You can see depressions in both the inferior leads and the types so let's talk about how a STEMI works, right? So like we all know when there's ST elevation, which is between 0 to 12 hours. But there can be a lot of different changes in the EKG that can show that someone may be about to have a STEMI or may have already had a STEMI. So the first one we see is a normal EKG. We see the P wave, the QRS complex, and then the T wave. The next level over we see is the hyperacute T waves, which occur minute to hours after any kind of cardiac ischemia. We see ST elevation in the first 0 to 12 hours, which is kind of the classic thing that we've been talking about, the elevation right here. And sometimes we see Q waves developing over the next 1 to 12 hours. So we see deepened Q waves right here. This is the most, one of the common ones we see, T wave inversions in kind of like, which happens in 2 to 5 days. So at least in kind of the way we practice law in the US, you know, when we're looking at an EKG, we like to compare to the prior ones, right? So we look at today's EKG and we try to find an old EKG to compare it. And if there's new T wave inversions, kind of like this, where the T wave is flipped upside down, especially when they used to be upright. That could be concerning for not someone having a STEMI right now, but may have had some kind of heart injury, like some kind of STEMI or some kind of cardiac ischemia in the past. Like maybe 2 to 5 days or in the past week, that is causing a T wave inversion. So those patients we usually check a troponin for as well. We're very careful that when we're looking at them, that we might repeat an EKG to see if the T wave stays the same or if it's changing back and forth again. After a few weeks to months, patients will start having like T wave recovery will kind of go back to normal. And sometimes you can see a persistent ST elevation. You see kind of on the far right here. And that can be according to like what we call a left ventricular aneurysm morphology. So sometimes, as we'll talk about later, after a heart attack, patients can, there's a lot of risk factors patients can develop, and a left ventricular aneurysm is one of those that we can see. And so, so we're talking about the STEMI right now. Usually in the US, our goal time is to have the patient from door to PCI at a cath lab within 90 minutes. And if there's no cath lab available within 120 minutes, say you're working in a tiny hospital in the mountains and you don't have access to a STEMI cath lab, you can give fibrinolytics within 30 minutes ideally. And this will basically help break up the clot that is clotting off the heart. The medications can be given through TPA or TNK, kind of depending on your hospital. Like different hospitals do different things. I used to do TPA a lot, but I think at UC Davis we definitely do TNK a lot more now. And this is all weight-based dosing. And there's about a 0.5 to 1% risk of an intracranial hemorrhage when you're giving someone TPA or TNK. And we'll go over, we'll just go really quick right here. So this is a list of the contraindications, right? So at the top half of the list is the absolute contraindication. So if a patient, has had any of these, has had a prior, intracranial hemorrhage, has a known cerebral neoplasm, has an arteriovenous malformation, any of these things, you can't give the patient thrombolytics. The second half there, the relative contraindications, those are a little more subjective, right? Things like active peptic ulcer or current use of anticoagulants or major surgery. Those are things that are probably will increase the risk of the patient receiving, TPA or TNK. But, if the benefits outweigh the risk, you can definitely have a conversation and discussion to see if that's something you want to do. You can give nitroglycerin, but you do want to, to help relieve some of the pain, but you do want to avoid this, especially if you're concerned for a right-sided EKG, or if the patient recently used phosphodiesterase inhibitors like Viagra or some other medication like that. Generally, morphine is only recommended if you need pain control. There's been some, I think, research that said like morphine interacts with aspirin and their antiplatelet effects, but the most recent research I could see was that it doesn't actually affect aspirin that much, but that's kind of the reason why some people say to hold morphine only if you need it for pain control. And then you want to heparinize the patient either with Lovenox or with unfractionated heparin. And I think, yeah, this is what we were talking about earlier, right? The atorvastatin. So definitely, I would definitely give 80 milligrams of atorvastatin right away for patients who have a STEMI. But again, I need to look a little more into the end STEMI part to see kind of what the practice is there. And usually things like beta blockers or ACE inhibitors or ARBs, those are usually given after a PCI. So it's not something that we do in emergency medicine that much. Any questions here or thoughts here, or how, you know, kind of different approaches to STEMIs that, you know, other people here have tried before?
In Vietnam, we don't usually fibrinolysis. If the patient has the elevation myocardial infarction, we usually inform another center. We have a cath lab, so we transfer patient very quickly, to the hospital with the SA for the patient. And we also use atorvastatin, but the dose is lower than in your presentation. We usually use about just only a half a dose atorvastatin, 40 milligrams. And yes, and rosuvastatin we usually use it only 20 milligrams.
Okay.
Because yes, because in Vietnam many many study and many research show that high dose atorvastatin, the same you or rosuvastatins make the patient more makes the patient increase liver enzyme. So we lower the dose of atorvastatin and rosuvastatin.
Oh, interesting. So what you're saying, you said you don't use that's really interesting, the lower dose. I have to read a little bit more about that as well. So what you were saying, you said you don't use fibrinolytics in Vietnam, right? You just go ahead for the PCI, the cath lab. So you try to find them a STEMI center and have them go there. Is that how you usually approach it?
Some situation are very far. The center can take cath lab. Some center use fibrinolysis, but now in Vietnam, we are a lot of center can take the PCR for the patient.
Okay.
So, yeah, so we usually transfer the patient to another center to take cath lab. And after you explain many things for fibrinolysis in the patient with myocardial infarction, a lot of patients, most patients and most relative of the patient don't want to use fibrinolysis. They just want to use stent or DSA for the patient. Yeah.
Okay. Oh, that's interesting. Yeah. That's really interesting.
Yeah.
Yeah. Anyone else have anything that they want to add or share, or any other experiences? Okay, we'll move on to the next one now. So let's look at this EKG. And like we talked a little bit about, you know, the Pales mnemonic, right? So what do we see right here? What are we concerned about here?
Actually, it's the depression in V2, V3, and V4.
Exactly.
So we must check the EKGs in V7 to V9.
Exactly. Excellent. So just so everyone can kind of catch up, right? So what we see here is we see ST depressions, right? V2, V3, V4, and V5. We don't really see elevations anywhere here. But what we want to do is we see the pressure without any elevation. So what we want to do is we want to go back to this mnemonic right here, right? So we see them in V2, V3. So what we want to do is we are going back to this mnemonic here. And the anterior leads are reciprocal changes for the one before, for the posterior leads. And so when that happens, when we see anterior depressions, we want to think, is there any posterior ST elevation? And the issue, we're not going to see it in a regular EKG, because remember, the leads of V1 through V6 are precordial, so they're going over the anterior part of the chest. So what you want to do is this is where we do a posterior EKG placement. And so what happens here is, instead of having V4, V5, V6 go around the front of the chest, we put them right on the back, V7, V8, and V9. Just like this on the back right here. And you have to make sure, because the computer's not going to automatically do that for you. So you want to make sure you change the leads on your EKG sheet to V7, V8, and V9. And if there's some, and then that way it'll show if there's any ST elevations in the posterior part of the heart right here. So here you can see right here, tiny low elevations V7, V8, and V9. These are all posterior MIs. When we see ST depressions in the anterior leads, we can sometimes see tall, broad R waves and upright T waves, and a bigger R to S ratio in V2. Those are all reasons that sometimes you can that can suggest you to do a posterior EKG to take a look at the back there. What about this one? Is this a normal EKG? Is this a STEMI? Would you send someone home based on this? What would you do if the tech hands this EKG to you?
So in this ECGs, we can see that the peak T wave in the anterior list. I think we call this. It had a special name like the winter size.
Exactly. Very good. Excellent. So this is what we call De Winter syndrome, right? So this, exactly, that was an excellent explanation. This is basically like an anterior STEMI equivalent. So what we're seeing is we see tall, very prominent symmetrical T waves in the precordial leads V1 through V6. So we can see these very tall T waves here. They're very upsloping. And there's a little bit of a depression at about 1 millimeter or so, especially in the precordial leads. We don't see any ST elevation, just these tall, very broad T waves. And you can see sometimes, it's not that well here, we can see a little bit of reciprocal, about 0.5 millimeter to 1 millimeter ST elevation in AVR. And this De Winter pattern, this is seen about 2% of acute LAD occlusions. And so, this kind of patient can't, this is not easy to see. Sometimes it just looks like a normal EKG. They're very easy to miss these kind of peak T waves. So kind of being aware of this is very important in terms of catching this kind of syndrome here. So this is considered an anterior STEMI equivalent, and you definitely want to talk to your cardiologist if the patient's having chest pain and kind of making troponins about whether or not they need to go to the cath lab, especially for the left anterior descending artery here. What about this EKG right here? So a technician hands this EKG to you. What would you do? Do you sign off? Do you go see the patient? Do you call the cath lab? How would you approach this EKG? You can share, or you can answer in the chat if that's easier. Any ideas? So this right here, what we're seeing right here is ST elevation in AVR, right? So this is sometimes for this type of EKG, you have to, depending on where you practice, some cardiologists don't really consider this a STEMI. But we see like very small ST elevation, diffuse ST depressions throughout many of the precordial leads, and a little bit here in, lead 2, right here. And so with the, exactly, so I know a couple people were answering the chat. So an AVR ST elevation usually suggests a left main artery occlusion. it may not be completely there, but sometimes it can show like partially there as well. There are a couple they're still doing a lot of research in this area, but there are a couple mechanisms, including like you get submyocardial ischemia with ST depression in the lateral, produces reciprocal changes here depressions, and this is the reciprocal ST elevation, or you may have an cardiac infarction at the basal septum, kind of the bottom part of the heart that's producing the AVR. You know, there's a lot of different ways to approach this. Some cardiologists will say just, you know, admit them to medicine and they'll continue to monitor their troponins. But this is definitely something to kind of be aware of, that, you know, depending on where you practice and your specialty, this is considered a STEMI equivalent as well. What about this one right here? Normal EKG or send them home? What are you doing with this one?
I think it's T-Swollen syndrome, but I forgot the type A or type B.
Good, right. This is a Wellens, exactly, right? So there's two types of Wellens. Excellent. What we see here, right, there's two kinds. So the first one, pattern A, is the biphasic one, right? It goes up a little bit, comes down a little bit, comes back normal. So this is the normal, this is the type A Wellens. The type B Wellens is here, where we get a very symmetric and deep T wave inversion. So in this case right here, we see a little bit of both. It's really more of the type B one where we get the deep T waves, but here maybe it goes up just a little bit. Here we see pretty deep kind of T waves. Wellens is thought to be kind of a, Wellens is really kind of thought to be a kind of transient interior STEMI where the heart is closed off a little bit and then opens up again. And the reason why it's important is, you know, your EKG may not be very successful in capturing an EKG with a Wellens there. Sometimes you can get reperfusion of the LAD due to the, you know, maybe if you give them aspirin or the vessel opens up a little bit, which leads to improvement of the chest pain. But this is kind of, again, this is similar to the morphology we saw earlier, right? It starts out as a biphasic T wave, and as it goes along, it starts out as A and then kind of goes along into B as time goes on. So the coronary, the heart flow in a Wellens is very unstable, and the LAD can really reocclude at any time. And if this happens, usually the first thing that happens is a normalization of the T waves, where it kind of becomes upright again. Usually this is when you have a hyperacute STEMI again, and you start having chest pain. And if the artery remains occluded, then the patient here is really developing an anterior STEMI. So again, right here, we can see them going a little bit deeper, and a Wellens can really be anywhere along this spectrum right here, you know, from a biphasic to kind of moving on to a deeper T wave inversion. This should be one of our last ones. What kind of EKG is this? Normal, or can we send them home, or do we need to activate the cath lab? Any ideas you want to share in the chat? That's fine. I think someone just wrote in the chat. Let me see what someone wrote. Excellent. This is a normal left bundle branch block. So, what we see here, this patient meets left bundle branch block criteria. So, QRS is greater than 120 milliseconds. We see a dominant S wave in V1, and really broad monophasic R waves in the lateral leads, in kind of 1 and in AVL and in V5 and V6. There's no Q waves that we see in the lateral leads. We see an absence of Q waves here in the lateral leads. And there's also a prolonged R wave peak time, about greater than 60 milliseconds in V5 and V6. This is a normal left bundle branch block. We don't have to activate that. We can just kind of continue working them up. And what about this one right here?
EKG showed us short big Q from V1 to V4. I think it's many days later, myocardial infarction.
Oh, like a late myocardial infarction.
Yeah.
That's definitely possible here. What this is and these are like pretty tricky to read, right? So what this is trying to show here is what we call Scarbosa criteria.
Yeah.
So this is kind of one of the rules that we have here to help us, left bundle branch blocks can be really tricky, right? Because it's normal to have some ST elevation, especially when someone is sinus tachycardic and with a left bundle branch block. So these are really hard to figure out, is there a STEMI or is there not a STEMI? So we've used these criteria called the Smith modified Scarbosa criteria. And there's basically 3 rules that we see here. There's the first one is any lead with the elevation of 1 millimeter, any lead with kind of a 1 right here. So we have concordant ST elevation greater than 1 millimeter in leads with a positive QRS coming. So if the QRS goes up and this goes up more than 1 millimeter, that meets the Scarbosa criteria for a STEMI. And then the second criteria is here, if you have concordant ST depressions greater than 1 millimeter in V1 through V3. So this is going down and this goes down greater than 1 millimeter in any leads V1 through V3, that would also meet criteria for Scarbosa criteria for STEMI in a patient with left bundle branch block. And the last one, there's 2 different criteria. There's the original Scarbosa criteria and the Smith modified one, which is now, I think it was externally validated probably about 2015 or so when they did a bunch of tests to kind of validate it. So we usually are using this a lot more now. Originally, it was like a 5 millimeter increase here. That we can see as like a discordant ST elevation, but now what they're doing is they're saying it's 25%. So you want to look at this entire thing right here. Like for example, right here, we see it's 15 millimeters right here and 5 millimeters right here. We want to look at the ratio of that. So 5/15 is 0.33, which is greater than 0.25. So this also meets criteria here. For example, if this was only 2 millimeters, it wouldn't be greater than 0.2. The ratio would not be greater than 0.25, and so this would not meet the Scarbosa criteria. So the main change here is it used to be just a 5 millimeter elevation, but now we're using a proportion between the QRS complex and the ST elevation that is greater than 25%. That's pretty much all. I know that was a lot of content to cover, but I'm around to want to talk about more questions or share about anything that we've learned or seen in our clinic or anything. We can definitely chat about that as well. Or if anyone needs to go, that's okay as well. There's no kind of pressure to stay. You can share, or you can type it in the chat.
Any emergency department, so we easily visualize the STEMI because when you see the EKGs, we see the STs elevators. So when the patient had the left bundle branch, we use check more time to analyze the EKGs. Like you said, we based on the Scarbosa size and modify to realize the ischemic for left bundle branch. And have the non-STEMIs become use the chest band and higher turbulence. So we must do many different diagnoses about the pneumonia or tachycardia, and we use many to check the X-ray, check the find the infection to different diagnose about the patient have the non-STEMI. Yeah. Maybe some case we send the patient to the cath lab for the different diagnose. We check the cath lab, is the patient okay? So we constantly choose the reason why it's higher turbulence. So
yeah, definitely. Like for the scar, but like I probably should have it memorized. I always, every time I have a left bundle branch block patient or a PACE patient, I always double check the Scarbosa criteria again, because it's hard to remember, right? There's a lot of different rules. You got to remember the proportions and the elevations. I always, take a minute to double check and just, make sure that we're not missing something there.
I totally agree with you. Because in our department, in emergency, I think in emergency in another hospital, the same year we have to receive many serious patients with many disease, many kinds of disease together. For example, heart, for example, kidney failure or infection. Kidney failure and infection are the two common situations we usually receive in our department. So in that situation, troponin T or troponin is usually very high. So in that situation, we took 1 hour later for troponin. We don't wait the result of the troponin when the patient admission. We continue took troponins 1 hour later. And we compare together and to determine the patient needs to cut lab or the patient just stay in our hospital to wait for another result to make a right diagnosis. Yes.
Yeah, definitely. I agree.
Yes.
With that. Any other ideas or any other questions that anyone else has? Or any other?
Jonathan, in Vietnam, we receive a little patient use sildenafil. Yeah. So we very easy to use nitroglycerin for patient. And I think in another place in another country, I think more patient than Vietnam use sildenafil. So if you receive the patient with myocardial infarction, with chest pain and high blood pressure, which medicine, with IV medicine, you advise for us to use it when the patient use sildenafil first before?
If you're, I think it depends on how high it is. What you're saying, if they already are using sildenafil, I think it really depends on how high they are and like how sick they are, how much chest pain they're having, and how much like how high their blood pressure is. Generally, if their pressure is, and then this is kind of a tricky, right? So there's not like necessarily a great answer to it. If their pressure is like, be over, like 100 or something, I may give them any, give them any nitro or anything like that. Because I think if you, the concern is if you don't want to, make the heart failure any worse there. So I would probably hold off. But again, it's hard because it kind of depends on the clinical picture that's going on. And it kind of depends on how sick they are and how high the blood pressure is. Usually the beta blockers, a lot of times, like depending on your cardiologist, I've seen some cardiologists want to give beta blockers before if their their heart rate is really high or if their blood pressure is really high. But again, like a lot of these things, it really depends on the cardiologist you're working with.
Yeah. Usually, if you see the patient with pulmonary edema, with their blood pressure more than 20 or 200, and they have myocardial infarction with ST elevation, which medicine do you advise to control blood pressure in this situation? And the patient have used sildenafil before?
So sorry, say that one more time. So they're using sildenafil, and you said they have high blood pressure, and what was the other thing you said as well?
Yes, that's right.
You can, beta blockers are, I would probably pick a beta blocker of some sort, but like if they're having pulmonary edema, then I would be less likely to. You say they're having like pulmonary edema, right? that's a tricky one because there's not a really good one I can think of right now that would be good. I would probably have to like defer to your cardiologist and ask them, what they want. Because if they have pulmonary edema, then like, the nitros and they're, because that's a tricky one. I don't have a really good answer. I'm sorry. I can look into a little bit more, but with the pulmonary edema, because if they're going into heart failure or shock, then I don't want to do the beta blocker. But then if they're doing the if they're already on sildenafil, then I want to do the nitro. So that's a tricky one. I don't have a really good answer. I probably ask the cardiologist and see what they say.
Thank you. I try to find more information and contact you.
I will look into it too. And we have the group chat that you can always share or ask information to. But I have to think about that a little bit more. I don't have a really good answer for that one. Does anyone else have an answer on what they would do if using sildenafil and there's pulmonary edema? How would you control their pressure?
Yes.
Anyone else have any other thoughts on what they would do? Yeah, that's a really good question, and I'm sorry I don't have the answer to that. I don't know if Ryan is there. Ryan's an expert in this, but I think he may be busy seeing patients right now.
Thank you, Jonathan. Thank you, Sultan. Very helpful topic today. Very great. Because we have to receive many patient lines you show on your presentation today. Okay, it's very great. Yeah,
of course. Thank you all for coming. I really appreciate you all coming every week. I'm leaving tomorrow night because I still have to work tomorrow. So me and Shakira are leaving at night, and then I think Saturday morning is when we arrive. So in a little bit, but I'm looking forward to it. What was that? I'm staying wherever Shakira is staying. Wherever she stayed, I'm staying too. Yeah, I forgot the name of it. She likes that one. I know she likes that one a lot. So I just go with her. Wherever she goes, I just go along. I just tag along with her. I know. I'm looking forward to it. Thank you again. Thanks, Scott and Ryan, for joining as well. Bye, everyone.
See you in Vietnam. See you in Vietnam soon. Yeah.